And we're going to pick up today on day 6 with Wolff-Parkinson-White. So I'm on page 64 of your workbook. So if you'll go ahead and turn with me there, and let's jump right into it. So we're continuing the story. We're still talking about the atrial arrhythmias. Oh, by the way, what's the difference between an arrhythmia versus dysrhythmia? So if we take the word, so arrhythmia actually means the absence of a rhythm. So for instance, when we say asystole, we're saying the absence of systole. So arrhythmia literally translates to the absence of a rhythm, which the absence of a rhythm is actually asystole. However, uh, a better term would be dysrhythmia, but it's just arrhythmia is a word that we've had for so many years. It's just been a part of the conventional language. So you will hear the term arrhythmia, but often we really should say dysrhythmia. However you want to use it, that's up to you. Just know the difference in what the words actually mean. Okay, so now we're still in the atria, and we're talking about, for instance, we've already covered the SA node. We talked about, for instance, we have, let's say, wandering atrial pacemaker. We have multifocal atrial tachycardia. We talked about AV nodal reentry tachycardia. We talked about, for instance, in A flutter, we have primarily one pacemaker site. That's why you have those flutter waves that all look the same, and then eventually a signal goes through. That's primarily one pacemaker site in the atria. However, in AFib, we have multiple pacemaker sites primarily in the left atrium. Okay, so now we're still in the atrium, but we're going to talk about a different spot. And this brings us to Wolff-Parkinson-White syndromes, or Wolff-Parkinson-White. So one of the things that happens is, well, first let's describe what it is. So you know how normally the signal should go from the SA node. It should travel from the SA node through the Bachman's bundle, through the internodal pathways to the AV node. Of course, I'm just reviewing the conduction pathway. We've talked about this multiple times. But once it gets at the AV node, we know there's a little pause there. The signal now travels through the bundle of His. It goes through the right bundle branch, the left bundle branch. Of course, the left bundle branch, as we've said many times, has two fascicles. We have, for instance, an anterior fascicle of the left bundle branch, and then we have a posterior fascicle of the left bundle branch, okay? Make sure you know the blood supplies for that. For instance, we said that the left okay, so obviously the right bundle branch, that's going to be supplied by the right coronary artery. The left bundle branch, well, the anterior portion is supplied by the left coronary, specifically the left anterior descending, and then the posterior fascicle of the left bundle branch is supplied by the right coronary artery, okay? But in Wolff-Parkinson-White, what happens is instead of the signal going through the normal pathway and then going down, for instance, all the way down to the Purkinje's, what happens is the signal actually, so let's just look at let's look at a normal rhythm. So I'm at this bottom part. So normally the atria are at rest. You should know this story by now. So call it out to me. We have atrial at rest. Then we have atrial depolarization. Let's just repeat it all for the people who hadn't got the story yet. The atria are sitting at rest. The atria depolarized due to calcium going inside the atrium. That's going to be phase 0, and that's the P wave. Then we have the PR segment. That's atrial contraction due to calcium going in. Behind here, we have atrial repolarization, okay? Of course, atrial repolarization is going to be due to potassium leaking out. It's going to be phase 3. We just can't see it in the EKG because it's hidden by the QRS due to the signal being stronger. Now, let's go down in the ventricles. So for the atria, I said there are 4 steps. Those 4 steps are the atria are at rest, depolarization, contraction, repolarization. We're going to have the exact same 4 steps down in the ventricles. The ventricles are at rest. That's this PR segment. Then the ventricles have to depolarize. They have to get excited. They have to have positive energy going into those cells. For instance, that happens during the QRS. Of course, all of this is due to sodium going into the cell. The Q represents the ventricular septum. The R represents the anterior wall, and the S represents the posterior wall. I've said this probably 50 times already. Now, then we have ventricular contraction. That's going to be the ST segment. We're going to talk about the ST segment later today when we get to infarction. But during the ST segment, that's contraction. That's going to be phase 2, and the electrolyte there is calcium. Then we have the T wave, which is ventricular repolarization. That's going to be phase 3. The electrolyte is potassium leaking out. Okay, and then sometimes we'll have a U wave. Of course, the U wave is what's called automaticity. That's where you have activation of the sodium-calcium exchanger. So calcium and sodium are just switching places, okay? So that's what should normally happen. However, in Wolff-Parkinson-White, notice how we do have a P wave, right? So the signal that means that the signal first landed at the SA node. That's why we have a P wave. And we notice that we have a P wave, for instance. We have a P wave consistently, but one of the things that we're noticing here is, so normally what should happen is after the atria depolarize, so that means that the signal lands on the SA node, it spreads throughout the atria, and then it lands on the AV node. Well, in order for that to happen, so once it lands on the AV node, the atria now contract, and we would see that in this flat portion. That's the PR segment. But notice here in this situation here, let me just draw that a little larger in red just to highlight it a little more. Notice that we had a P wave, but then it's no longer this little flat section like it's supposed to be. It's kind of this upsloping section here. Okay, this little upsloping section, what's happening, so notice that it happened pretty quickly. What's producing this is the signal, instead of just going from the SA node to the AV node, there's an accessory pathway where the signal actually goes a different direction. So it would kind of be like you're supposed to go in your house and you normally go through the front door. So you normally put your key in, turn the key, and then open the door. Of course, there's a little pause, right? You don't just go in. Well, what happens now is you're trying to sneak in the house because you snuck out. You and your boyfriend, girlfriend were doing some stuff you shouldn't be doing, but your parents are coming home and you got to get inside very quickly. So what you do is you go through a different direction. You sneak in through the window. So that's what's happening in Wolff-Parkinson-White. The signal is sneaking in through this accessory pathway here called the bundle of Kent. So remember how we have a bundle of His, but this little guy is called the bundle of Kent. So the signal just kind of sneaks in there, but it does still make it to the AV node. It just didn't go the normal direction. So it didn't go from SA node to Bachman's bundle internodal pathway to AV node. What it does is it goes from SA node and sneaks in through the window through the bundle of Kent. And because it happens very quickly, that's why we have this very quick upstroke here. And by the way, this little upstroke here, this is what's known as a delta wave. Okay, so in Wolff-Parkinson-White, one of the things that we're going to notice for sure is that it's going to have this characteristic delta wave. Now, here's what I want you to notice though. Because of this little delta wave, I want you to compare, for instance, the PR interval. So this is a normal PR interval. So from the start of the P to the start of R is what's called the PR interval. Well, now in Wolff-Parkinson-White, here, let's show you on this this first one. Let me clear this part here. And I want you to notice this little section here. Because it's happening faster, what it does is it actually brings the P wave closer to the R wave. So a way you would say that is it's a shortened PR interval, okay? Because it's happening faster, the time from the P wave to the R wave gets closer together. So we call that a shortened PR interval. So what you notice with Wolff-Parkinson-White is you're going to have this characteristic delta wave. That's that upsloping uh, wave right after the P wave, and a shortened PR interval. Now, it it may cause problems, it may not cause problems. It depends on, for instance, how severe it is and how long it's been happening. It's something that the cardiologist will definitely want to evaluate. But for instance, today, if it's the very first day that it's happening, and it could be caused by a number of different reasons. There are lots of reasons, just like every arrhythmia can be caused by lots of things. The biggest cause of any arrhythmia is depolarization. So, spontaneous depolarization. And the number one cause of spontaneous depolarization for any cell in the whole body is ischemia. So, ischemia, for instance, can cause spontaneous depolarization in the heart. We call that a tachyarrhythmia. Ischemia can cause spontaneous depolarization in a muscle. We call that a muscle cramp. Ischemia can cause spontaneous depolarization in the brain. We call that a seizure, right? So ischemia is the number one reason for any membrane becoming more likely to depolarize. So for anything that's due to a depolarization issue, you want to also investigate whether ischemia is something that you need to address. And often that's just treated with some oxygen. So just supplemental oxygen. So for instance, you have a patient, let's say in an emergency setting, it's not going to hurt them to put them on maybe 2 liters per minute via nasal cannula, 2, 3, 4 liters per minute via nasal cannula, because that's the most common reason for any membrane depolarizing. So it depends on how symptomatic they are today in terms of what other treatment will be needed. But either way, this would be a great patient to just go ahead and refer them to the cardiologist for further workup, unless you're already the cardiologist, of course, and then you'll treat them. But for instance, if you're in emergency medicine, family medicine, internal medicine, or something else, a cardiac workup would be a cardiology consult would be a good thing to do. So that's Wolff-Parkinson-White. I'm not going to go further into it just because I'd be getting more into the management, but a lot of it's going to be based on the symptoms and how severe the symptoms are. Okay. Any questions about Wolff-Parkinson-White? What I want you to know is Wolff-Parkinson-White has that characteristic delta wave and a shortened PR interval, and it's due to the signal going from the SA node and kind of slipping through, sneaking in through that bundle of Kent here. Okay, that's Wolff-Parkinson-White.